Hello, anesthesia enthusiasts, and welcome to another episode of Style Points. Today on the podcast, we are joined by my friend Dr. Tyler Guidugli, who will be talking to us about the challenges of implementing point-of-care testing and why it's all worth it. Feel free to submit the title of this podcast to the annual Best Double Entendre-themed Title in an Anesthesia-themed Podcast Awards Selection Committee. I'm really hopeful that this year might be my year. Before that, I want to turn it over to Nate Moore, who will be introducing this month's RSI, which, I'll remind you, stands for Resident Selected Information. Hey, that's another double entendre.
Thank you, John. I'm thrilled to introduce Dr. Lauren Pferdmenges, who is no stranger to spooky season. She was born on a Friday the 13th and will be taking the black cats dancing across her scrub cap with us as we delve into the swirling mists of metacognition and discuss how to make learning new procedures a little less scary. Welcome, Lauren.
Thanks, Nate. So if you're an anesthesia intern like myself, or if you're getting ready to start your intern year, you're probably wondering how you're supposed to prepare for all the procedures you'll be doing, from arterial line and central line placement to bronchoscopy. The good news? There's actually a scientifically validated framework that many anesthesia residency programs use to assess residents' procedural abilities based on key competencies. The assessment tool that I'm referring to is called the Direct Observation of Procedural Skills, or DOPS. Now, as a full disclaimer, I'm far from an expert in any procedure. I've just spent a lot of time looking into effective and efficient strategies for improving my own skills before CA1. Now, the Direct Observation of Procedural Skills, or DOPS, was implemented in 2016 and discussed as part of a systemic review article by Guidugli et al. In 2018. It compiles 28 studies that utilize the DOPS model to evaluate everyone from nursing students to medical students to residents from a variety of surgical specialties. This tool enabled evaluators to provide specific and actionable feedback that trainees could implement for efficient skill improvement. The result demonstrated improved performance and greater self-confidence when their procedural skills were evaluated using DOPS. But as anesthesia interns, much of our time during intern year is spent on off-service rotations, and the opportunities to place a central line there aren't exactly plentiful. So with this in mind, I'm going to discuss some concrete and actionable ways that an intern can prepare, specifically within the DOPS-assessed competencies of procedure prep, technical ability, and insight. Firstly, I'll discuss preparation, which DOPS refers to as ergonomically arranging your workspace, acquiring clinically indicated equipment, and ensuring assisting staff are present. Even with the best preparation, unforeseen things can happen. This is why it's so important to control the controllables, like familiarizing yourself with your institution's procedure kits and how you'd use them to set up for a procedure. I found it helpful to take a kit home, without the sharp things like needles, of course, and to find a YouTube video on how to set up using that particular kit. While it might seem trivial, when you're nervous and in the moment, it can be tremendously helpful to start off strong by confidently setting up your workspace beforehand. It's also worth spending some time acting out the procedure steps using the equipment in the kit to help you feel more comfortable with them. It's equally important to refresh your memory on the relevant anatomy of a procedure and which landmarks you should be looking for or trying to avoid. One of my favorite ways to do this is with an app called ANSO, which features tons of clear ultrasound images and highlights the high-yield anatomy and positioning considerations for common nerve blocks. Tying this all together, I would highly recommend making somewhat of a procedure note, which includes high-yield reminders and key steps of each procedure. While you might remember these things in the moment, it may be a while before you practice the procedure again, so it's helpful to have all of this info in one place and readily available. I personally like to use my phone's note app for this because it allows me to easily search up for and pull this info up on a particular procedure by name. Another key competency, of course, is technical ability, which is defined as having manual dexterity and confidence, or demonstrating correct procedural sequence with minimal hesitation. Now, we all know that there's no substitution for repetition, so it's super important to take advantage of the opportunities that do come along to perform these procedures, whether it be in the ER or in the OR. Now, of note, it can be tempting to avoid procedures early on out of fear of failure or fear that somebody would need to come and step in. So I think it's really important to remind yourself that you're not bad at this, you're just beginning. But when these opportunities do come along, how do you actually improve your technical skills? Personally, I've found a few ways to optimize my chances of success. One of the most important and underrated being optimizing positioning, whether this means asking to raise the bed or table or taking an extra 60 seconds to find firm and stable hand position while holding an ultrasound probe. There are also procedure-specific things that I've picked up throughout people over the year. For patients who are difficult IV sticks, for example, this includes the importance of placing a really tight and distally placed tourniquet and having gravity be in your favor when positioning their arm. Lastly, I want to discuss insight, or knowing when to ask for help or stop the procedure. One way to gain insight is by reflecting on your decision-making style. I'm specifically referring to the framework that when learning procedures, people often tend to make errors of either commission or of omission. Those who are prone to errors of commission tend to be more confident and action-oriented, often, quote-unquote, going too far or overshooting their target with decisiveness and momentum. Such errors include going through and through or inserting a needle through the back wall of a vessel. On the other hand, those who make errors of omission tend to prioritize harm avoidance, and their mistakes come from hesitation during critical moments. For example, inserting a needle too shallow and missing the vessel entirely, or not advancing adequately and losing venous access. Why does this matter? Research on metacognition in procedural learning demonstrates that trainees with higher self-awareness show better skill acquisition and task engagement, and knowing your own tendency allows for self-correction. For example, those who are error commission prone could remind themselves consciously to slow down and take deliberate pauses, whereas someone who's prone to errors of omission can try to consciously commit to completing maneuvers by reminding themselves that avoiding complications out of fear might be less likely than failure due to incompletion. With these competencies in mind, hopefully you'll be ready to nail your next procedure, even as an intern.
I thought long and hard about it. And I was like, does come with this profound person, or do you just come up with someone who it's kind of reminds you to take it easy every now and then and enjoy life and have a margarita? So.
Tyler Guidugli, thank you for joining us.
Thank you for having me, John. I'm excited to be here.
I'm excited to have you here. Now, you got pulled over for speeding on the way over here, and I'm really excited for you to tell the story.
Yeah, so I was, just minding my own business, making my way into, the podcast, and really wasn't going too terribly fast, and I thought, but it turns out going 82 and a 70 was too fast this morning, so the kind officer pulled me over and asked me if I was making my way into work into the hospital, and I said yes. He said, do you work there? I said, I'm a physician, and he said, well, just have a nice day, slow it down a little bit.
You didn't tell them that you were about to be a guest on the very famous Style Points podcast? You're sure that's not what got you off?
That would have been a nice plug. I really should have put that out there, although that may have actually gotten me a ticket instead of vice versa.
Yeah, it probably would have exhausted the Style Points budget to pay for your ticket there.
Exactly.
All right, so let's just back up a little bit. Tell me a little bit about yourself. What's your bio? Where did you train?
Yeah, so my name's Tyler Guidugli. I'm one of the newer faculty members here at the University of Cincinnati. Originally from this area, so grew up here in Cincinnati, Northern Kentucky, and then went down to University of Kentucky for undergrad. Spent 4 years there during the run of multiple Final Fours and the national championship, so that was a big deal. And then I kind of always knew I wanted to do medicine. Went in undergrad planning to do medicine. Was a biology major, and then went to the University of Pikeville, so Eastern Kentucky for medical school, which was an experience, and it was a good one, but it was definitely an experience. And then made my way to the University of Kentucky for anesthesia residency, and then did an OB anesthesia fellowship following anesthesia residency, and then kind of came back home.
So it's time for my favorite get to know you question. If you could have dinner with anyone in the world, could be somebody from the past, present, or even from fiction, who would you go out to dinner with and why?
So I will say I'm historically bad at thinking about and answering these questions, but I tried to put some thought into it, and my answer is going to be Jimmy Buffett. I think I'd like to have dinner with Jimmy Buffett. He's a very interesting guy. I think the conversation would be interesting, and I've been to a couple of his concerts. Really like his music, and I think it's a nice reminder when you're listening to his music that, despite all the crazy things going on in life, it's nice to kind of slow down every once in a while. And
forgive my ignorance here, but what are Jimmy Buffett fans called? Do they have like a specific name associated with them?
Oh, yes, they do, John. Parrot heads would be the name that Jimmy Buffett fans are called. And if I told you I had a foam parrot head device at my house that I've worn to his concerts before, that would be something that's true.
Well, I am going to need a picture for that, and that is the picture that we are going to use for the podcast for sure.
That seems very appropriate. That and a Hawaiian shirt.
Excellent. Well, I am looking forward to that for sure. So, backing up a little bit, what drew you to OB anesthesia specifically?
Yeah, so it's an interesting question. I was kind of one of those residents who could have seen myself doing any fellowship. I really enjoyed cardiac and critical care, and I really enjoyed OB, of course, as well. And I think the reason that I ended up deciding to do OB was a couple things. It kind of took I saw that the people that really kind of thrived and did OB anesthesia well kind of treated it like it was an ICU unit almost. The laboring patient you start the shift with is not the laboring patient you finish the shift with. People, fall onto and off of their labor curves, or just like they fall onto and off of their recovery curves in the ICU or whatever their clinical course may be. And so I found it really interesting to kind of merge all of the different areas of anesthesia where there's a little bit of critical care for the more sick obstetric patient. And then there's, of course, still OR time for cesarean delivery and all the kind of different OB procedures that we do. And then I thought neuraxial was, some of the most fun procedures that we do in anesthesia, and I really enjoyed that. And then I also think I'm a little bit of an adrenaline junkie, and, traumas are fun and interesting, but you get a little bit more of that kind of urgent emergent C-sections occasionally on OB. So that was kind of one component of it. But I think the other thing was that I felt like anesthesiologists are really well positioned in obstetric anesthesia to really change outcomes. And one of the core things that drove me to really understand that was there was a laboring patient. One evening I came in at, it's the typical coming at 5:00 on a Friday night, and they handed me off that this patient has been here for a couple hours. She keeps having recurrent decelerations. She does not have an epidural, does not want an epidural, and the obstetricians are concerned she's going to have an emergent cesarean delivery at any moment. And so, she doesn't want an epidural, so we just kind of just been letting her be. No one's really talked to her. I said, okay, well, let me just go have a conversation with her. So, an hour or so into my shift, I went and just sat down with her and I said, I'm Dr. Guidugli, I'm with anesthesia. We've noticed that, your baby's heart rate may not be tolerating labor as well as we would like it to. And, we're concerned is that we're going to have to move our emergently back to the operating room at some point. It's like, things look okay now, but things may change. And, this is kind of, I've heard you're not really interested in an epidural right now, and, I'm totally here to respect your decision, but this is a little bit what an emergent C-section looks like with an epidural, and this is what it looks like if you don't have an epidural. If we have an epidural, you'll be awake for the birth of your child, and your spouse or your partner can be there, and all these good things. And she said, just let me think about it. I said, that's totally fine. I'll circle back in about a half hour. And I came back, and sure enough, she was like, you know what, let's do it. Let's go for it. That sounds reasonable. And so I placed the epidural, and sure enough, I think it was about 2 hours later, there was a stat C-section from her room, and we went back to the OR, and they were, forever grateful that, what was still a very scary experience could have been an even more kind of scary and traumatic experience. And it was actually one of the only patients that has given me a gift over my career. They had made, this is a very Kentucky thing, they had made limoncellos in a mason jar, and were handing them out. So they had given me one of those for their experience, which I did not drink, but I did appreciate.
That's fantastic. Yeah, gifts for anesthesiologists isn't something that happens very often. I've only gotten one or two that I can remember. Typically, we're more the unsung heroes, partially because we give them medicine to make them forget us.
That's a fair point.
So something that I really wanted to ask you about is one of our shared interests, something we've spent a lot of time in the hallway and the lounge trying to figure out, which is point of care testing. So for our audience that might not be familiar, can you talk about what it is and the journey that you and I have been on?
Yeah, so point of care testing is kind of refers to a variety of different, what would historically be like laboratory based tests. So whether that be hemoglobin analysis, arterial blood gas or venous blood gas analysis, viscoelastic testing for hemorrhage, it could be a variety of different things. But the idea is taking something that has traditionally been a laboratory based test and moving it to the point of care or where the patient's actually being cared for, which in, maybe some spheres isn't as helpful, like maybe on a medicine floor, it could be helpful, but certainly in the perioperative area where we're in the OR and we're making, minute to minute decisions as physiology and as the patient is changing in real time, moving things to the point of care helps make those decisions in more of a real time instead of leading to a little bit of a delay when you're sending something off to the lab and relying on runners or tube systems and lab personnel to get the test up and running. So just essentially it's taking what traditionally are lab-based tests and then moving them into wherever the patient is at the point of care, whether that's the ICU or the OR, so on and so forth.
So we're just moving the lab as close to the patient as possible so that we can make those snap decisions, basically.
Yes, essentially.
So what labs do you think are most important to us in the operating room? What's most critical for us to have right away, and when would we need those?
Absolutely. So I think they're the two biggest ones, from my standpoint that I can think of are really blood gas analysis and then viscoelastic testing, which you and I have certainly been working on quite a bit over the last couple months. So thankfully, thanks to your effort, we now have point of care arterial blood gas testing and venous blood gas testing. And then hopefully here in the near future, we'll have viscoelastic testing at the point of care. I think those things are probably the two most important because it allows you to take your sickest patients and get the most critical information about their pH, what their electrolytes are doing, if they have a rising lactate, looking at their base deficit and their bicarbonate levels. And then the same thing with viscoelastic testing is taking a patient who is in the middle of a hemorrhage, whether it be a trauma hemorrhage, a hemorrhage from a liver transplant, post-bypass coagulopathy or obstetric hemorrhage. And certainly in my view, being able to assess those things very rapidly has been shown and does make a major difference in patient outcomes.
So not everybody, I think, might be familiar with the term viscoelastic testing, but they might be familiar with something called a TEG. Can you tell us about what a TEG is and what that stands for?
So TEG is thromboelastography. It falls under the umbrella of viscoelastic testing. So I like to use when I talk to the residents about this is like viscoelastic testing is akin to using the word like soda. And then TEG would be like Coke. And Rotem would be like Pepsi. They're just different flavors or different brands of the same kind of category.
That's perfect. That's a really good analogy to help explain things, I think. So what exactly are you trying to bring to the operating room then?
So we're in the process of trying to get at the University of Cincinnati, we have TEG 6S. At different institutions, they have different sorts of viscoelastic tests. For example, at Cincinnati Children's, they have Rotem. We have TEG 6S here, and at other institutions I've been at, they've had TEG 6S. The idea is to try and move one of our TEG 6S devices from the lab where it lives now to the point of care. And in our mind, the point of care is going to be, we have a sterile core that lives right behind our trauma room and at the intersection of like our cardiac and transplant rooms, and to essentially create a little critical care core where we're taking care of the sickest patients, and we have essentially almost a standalone lab to get the information that we need the fastest to help improve their outcome.
Sometimes when a patient is bleeding out in front of us, we have to have information to make decisions really quickly. Can you think of a time where having access to a faster lab might have led you to a different decision than you would have otherwise made?
Absolutely. I think one of the best examples that I have of this is during a really significant obstetric hemorrhage that I had during my OB anesthesia fellowship. And I think it kind of highlights the differences in at least time frame from laboratory-based testing to point-of-care testing. And so we had an otherwise healthy patient. She had no comorbidities. She was just having a normal labor. She had one prior vaginal delivery, and then she had some fetal decelerations, and we had to move back for an emergent C-section. As we know, the patients that have been laboring and on oxytocin for a prolonged period of time are at higher risk for hemorrhage. And sure enough, when they got her back to the operating room and got baby delivered, there was a pretty profound hemorrhage. And as we were getting another IV, we drew labs when we were placing it and then hooked it up. And we sent traditional labs to the main lab. And then we fortunately, where I did fellowship, had a point of care TEG success. So I went in and ran the TEG success. And if you're interpreting the tracing, you can get actionable results within a couple minutes. Specifically, in this instance, the thing that really made the biggest difference was fibrinogen. So we know that fibrinogen in obstetric hemorrhage is the most important coagulation factor. In fact, a fibrinogen level of less than 200 has a 100% positive predictive value for progression to severe postpartum hemorrhage. So it's really, really important that we're assessing fibrinogen rapidly. A Klaus fibrinogen that you get from the main lab takes 45 minutes to an hour. You can assess fibrinogen via the CFF tracing on the TEG 6S within about 3 or 4 minutes. So in this patient, we could see that her fibrinogen it was flat. I've actually never seen one look like that before. It did not even attempt to create a graph at all. It was just a completely flat line. So we were able to rapidly identify that, and then we were able to replace it quickly with fibrinogen concentrate. It's even more important for places that may not have fibrinogen concentrate because, as we know, to replace fibrinogen, you need cryo. And anytime you call for cryo, it takes them 20, 30 minutes to get it to the bedside because they have to thaw it. So in this instance, we were able to really control her hemorrhage rapidly and save her probably some additional blood product transfusion.
Yeah, that's a really big deal. So fortunately, we've been able to adopt the GEM 7000, which is our new ABG analyzer, and it's been really good so far. It sounds like really a simple thing. We ask for the department to purchase the device, we put it where we want it, and we run the lab. It's that easy, right?
So that's what I thought. I thought I just needed a TEG 6F, an Ethernet cable, and a dream, but it turns out it's a little more complex than that. So what I have recently learned, and I think you have definitely learned over the last little bit as well, is that there is a lot more nuance to bringing devices on to point of care, certainly than I would have ever imagined. I did truly think it was going to be a little bit, somewhat as simple as plugging the device in and connecting it to our server, and then it transmits the results from the lab. Why can't it transmit results from wherever the device is living? So what we have learned is that after meeting with the lab multiple times, is that there are a lot of nuances to it. One, the lab needs to have approval of it because it is their device, and needs to have some buy-in and some reasons to actually move it there. One of the things that we ran into specifically for TEG was that historically these have been torsion pin and cup spinning devices to measure clot strength. So the historical model for TEG and ROTEM was that there was a cup and there's a torsion wire in the cup of blood, and the cup spins and as fibrin strands adhere to the torsion pin, it creates a graph, and that's the typical TEG tracing that we get. As you can imagine, that is fraught with potential errors. If anyone bumps the table or anything like that, it would make the results inaccurate. And so when I had mentioned this to the lab, that was one of the things they brought up. Fortunately, the newer TEG 6S device and the newer, I think it's Rotem Delta, the newer, or maybe Sigma, the newer Rotem devices and TEG devices use piezoelectric crystals for clot penetrance, and that's how they measure it. So it's much less dependent on if there's table movement or vibration or anything like that. They're not very sensitive to that at all. So they're more adept to making them point of care. But with speaking with the lab, one of the important things that you have to have is a middleware that I was not quite aware of. So having a middleware to be able to communicate the results from the point of care device to Epic for not only resulting so that other people can see the results, but also for billing, is something that needs to happen before just bringing a device on point of care.
And so by middleware, you mean a computer program?
Yes, a computer program that has licensing fees and is associated with costs.
And these are costs that you would prefer not to come out of your personal paycheck?
Ideally, yes.
So let's talk a little bit about incentive structure within the hospital system. There's people that benefit from the change, our patients and us. That's the most obvious benefit that we see as clinicians. But that's not often the people that have to approve or maintain these devices. So how does this mismatch work? How does it play out when we're making a change like this?
Yeah, so I think it definitely can be challenging. And it's one of the things is that when we had some of these meetings with our own laboratory here is talking about like the clinical argument, and I think a lot of them after kind of going through things, they understand the clinical side of things, but when it still comes down to operationally and then also cost wise, that still plays a major factor. So I think one of the key things is that there has to be some financial input from your institution to help make these things a reality, and helping the people at play that are just looking at numbers understand that yes, there will be an upfront investment, and I think we all understand that that's not insignificant. The devices alone are run about $40,000 to $45,000 for a TEG 6S. Fortunately, we don't have to buy one. We're just kind of reallocating one in our instance. But to buy the software is an upfront investment to make that happen. So I think when you're approaching the administration to say, hey, this is something that we need and that would be really beneficial to our patients, yes, it's going to cost X amount of dollars. But when you look at the bigger picture, because TEG has been shown over many, many studies, over many, many years at this point, to lead to less ICU admissions, less TACO, less trolley, in cesarean history. So less transfusion-associated cardiac overload and less transfusion-related acute lung injury. Complications related to blood transfusions. In OB anesthesia particularly, it's been shown to lead to less hysterectomies, which is a really big deal when you're looking at someone's permanent fertility. And again, same things, less ICU admissions and less transfusions. So it's complex to try and bring this point to the administration where, yes, we're going to have to make an upfront investment, but over time, we will eventually save money when looking at less blood products being transfused. If we have one or two less ICU admissions per year, that is a significant cost savings. And so trying to frame it when you're talking to the administration, and yes, we'll have to spend a little bit, but we are going to, over time, actually save money by making a move like this. And the most important thing that you and I care about is you're taking the best care of patients.
One thing that I've noticed to be a little tricky in these scenarios is that even though we're one big hospital system, each department has its own specific budget. So even if we're saving money by not admitting a patient to the ICU, the lab who's running these tests just sees a chunk of their budget taken up by this device. So money isn't saved by the lab specifically whenever we run these tests and find we can do something more on the preventive side of things. So how do we navigate this space where we're trying to bring everyone under the same umbrella? How is this our job?
And I think that was a little bit of an unanticipated on my end, kind of issue to run into is that, I agree. We're one big system, and I thought it was, we're going to improve care and save costs to the system. But as you said, each kind of department has their own priorities and their own finances that have to play a part in this. And so I think one of the reassuring things that I think has been part of this process is when I first started emailing back and forth with the lab about bringing this device on point of care, there was a lot of caution. There was a lot of concern. And over time, as we've discussed it more and more and had meetings in person, and I've got to know these people a lot better, the nice thing that I've seen is that after really making good clinical arguments and showing how we can kind of all benefit from this, there has been a little bit of a change in the ability to make this work. And so I think reemphasizing that, at the center of all of this is patient care and that this is the best thing for the patient. And I think they have started to understand exactly how important it is and starting to understand why we have to make decisions on a minute by minute basis. And so I think emphasizing that, because not everyone thinks the way we do. And so when you kind of explain to them, I think one of the examples I gave is when I had a liver transplant a couple weeks ago where we gave 70 units of product. And, which is a lot. Turns out that's quite a few units. And I think when you start mentioning things like that, I'm like, oh my gosh, well, yeah, of course that device would be helpful to you. And then I think also framing it in a way that we can help offload some of your staff as well by moving some devices to the point of care. It does take away some of the labor intensivity from the people within the lab. Now, it may create the point of care department may need a few more people, but the nice thing is that if you have people that are really invested in this, like you and I, we can kind of stay on top of the QCing and keeping up with making sure we have the supplies we need, and we can help offload the lab in some ways to be more of a symbiotic relationship.
So I feel like there's a version of this where you're a junior faculty member and you have a great idea, but you have repeated interactions that are roadblocks that sort of grind you down over a while. But you've persisted through all this. So my question for you, what do you think it is that keeps you going, that keeps you focused on making this happen?
I think the biggest thing for me is that I certainly, there have been some more roadblocks than I would have guessed. I knew it wouldn't just be a walk-in and this is what we're doing and that's how it's going to work. So I think I understood from the beginning that it was not just going to be a super simple process and that it would take some time. But the thing that really keeps me going in this is a couple different things. Number one, it's one of the most important, in my mind, technologies that we have that has been demonstrated to make a difference in patients' lives. And I've seen that happen, some of the examples that I've given. I've seen it happen over time. I've seen the real-time, personally, difference that this can make. So knowing that it's the best thing we're doing for the patients and trying to, staying up to date with the most up-to-date practice in ways that we can not only take the best care of patients, but also if we're using it and we're using less blood products and we're giving goal-directed therapy instead of kind of our traditional, one-to-one-to-one, transfusions, and we're doing exactly giving what the patient needs, blood products are not a benign thing to give. They have complications associated with them. We're kind of always on a blood product shortage. And so also just being good stewards of the healthcare system and making sure that we're giving the precious resources that we need and we're not just giving, kind of precious resources based on not as data-driven as we can. So I think what keeps me going is just knowing that this is one of the best things that we can do for patients that really makes a difference in outcomes. And that's kind of what keeps me moving forward, and particularly in obstetric hemorrhage too. knowing that this is such an important way to assess obstetric hemorrhage. And if we can save, one life or one ICU admission or improve one outcome, that to me is enough.
So let's try to go over a real life example where having access to one of these systems like TEG might help you make a different decision clinically.
So the nice thing is that, let's say you had point of care viscoelastic testing, point of care TEG, and we have an OB patient that's bleeding on the table or is coming back for an emergent D&C, and people are saying, well, let's get 2 reds and 2 FFP and let's just get products in the room. And oftentimes I'll say, well, let's send a TEG. Let's send a TEG, let's send coags, let's just get some data. And then we'll give things that we need to give to keep the patient stable, of course. But oftentimes I'll try to make a data-driven decision knowing how obstetric hemorrhage plays out. And so an example I can give you from a couple months ago is we had a really profound obstetric hemorrhage, and the obstetricians were asking to give FFP and all of these different blood medications. And I had already sent a TEG, thankfully, and it came back. And in this case, the TEG was profoundly normal. The patient had lost, I think, or close to 2 liters of blood, maybe a little bit under. And our TEG at that time was normal. And so they wanted to give some units of FFP and things like that. And we ended up holding off because at that time we didn't need any. And she was actually not bleeding any further. The bleeding had stopped with, D&C and removal of retained products. And we replaced her blood volume. But we ended up, not giving extra units in that case. So, saving that patient an exposure to blood products was a big deal. Now, if the fibrinogen was low, we would look to give something like cryo. And by getting a fibrinogen level on a TEG within a couple minutes, we can get that cryo much, much faster. So it could definitely make a difference there.
So what advice would you give for a resident or a junior attending who has an idea that they really believe in, but they might be having trouble getting traction on it?
Yeah, so I think I would definitely, if it's something that you really feel strongly about, then certainly don't give up on it. Just know, and I think coming in with the right mindset is probably the biggest thing. I came in knowing that this might be a little bit of a challenge, and people, when I had left other institutions that had gotten this pushed through, said it was a lot of work and it took a lot of meetings and a lot of convincing. And so that's a normal part of the process. Change is slow, and that's okay. It doesn't mean it's not worth it, and it doesn't mean it's not the right thing to do. So I think coming in with the expectation that it's going to be challenging, try to be as well prepared as you can and be ready to answer questions. There's no need to be defensive about anything. Like, the lab has, reasons for the questions they're asking and their priorities, and we have reasons for the questions that we're asking and our priorities, and trying to find a balance where all your priorities can align and you can get, a positive traction and positive outcomes for all parties involved is really the end goal. So working, with those people and just knowing that there's going to be road bumps along the way is expected.
So let's say over a long time horizon, maybe the next 5 to 10 years, you get everything that you want as far as point of care testing in our ORs. What does that look like?
So I think ideally we already have the arterial blood gas testing at the point of care with our new GEM 7000, thanks to your very hard work on that.
Well, you have also helped significantly with the meetings and with the rollout, so it's been a joint effort.
It has certainly been a lot of effort, so I think that is a huge start, and I think it actually that will, I'm hoping, lay the groundwork that that we can do this, we can show the lab, we can run tests without causing a lot of quality issues and without causing any CLIA laboratory standards issues. And then if we maybe can start ramping up and getting more of those devices someday to expand that coverage, and then getting a TEG success moved to the point of care, as well, and having a kind of, like I said earlier, a critical care core offsite lab essentially where we can run all the tests that we need to take care of the sickest patients. So when a trauma comes in or an obstetric hemorrhage happens, I can take a couple steps and I can get 2 labs within minutes that are going to change all of my decision making and patient outcomes. And I think that's where we really want to take this. We're such a high volume liver transplant center here that I think the TAG 6S being at the point of care is really going to make a difference on our ability to take care of our liver patients and how much product they're getting, and giving them the most accurate goal-directed therapies that we can give is going to, I think, make a big difference in their recoveries as well. So I think ideally in a couple of years, we'll have maybe a couple more ABG testing devices and at least one TAG 6S to be able to run everything, get real-time data, and get patients well taken care of.
Lastly, I wanted to ask you about your style points or points of personal preference that have helped you both in and out of the OR.
So I think there's a couple things that I would say. One, something that you and I kind of mentioned yesterday. Yesterday, I gave a talk to the residents on caring for the kind of intellectually disabled or patients on the autism spectrum disorder. And I think one of the things to just always keep in mind is it's easy to be jaded in medicine. It's easy to be frustrated by all of these different issues we've been talking about, whether it's from the lab or from administration, but patient care is kind of at the center of this. And so just being a good person and taking care of that patient and just talking to them and hearing them out and just listening to patients, listening to what they have to say. One just very brief example of this is yesterday on OB, I had a patient that had a cerclage a couple of years ago and kind of described how uncomfortable the experience was for her. And I went back and looked, and she had received chlorprocaine for her spinal for a cerclage, which is not uncommon to do. And that was actually what my plan was going to be, was to use chlorprocaine for the spinal for her. But after talking to her, I was like, well, let's switch to traditional bupivacaine. Her recovery is going to be a little bit longer, and I told her about that. But I said, I think you might be more comfortable if you really had a lot of visceral sensation from the chlorprocaine. And so that's what we did. And afterwards, it was very rewarding to go talk to her. And she was like, it was night and day difference. It was so much better than last time. I'm so much more comfortable. I don't care that my legs are numb and that I'm here for another hour or so. I didn't absolutely hate that whole experience. And so I think just listening to patients and talking to them is a huge thing that's really important. And then one of the other things that I personally like to do, and I'll have to give credit to one of my mentors from residency, Shira Gambrell, that I've tried to impart on the residents here, is anytime I place an arterial line, I like to put the pulse oximeter on the same extremity that I'm doing the arterial line on. Because that way, once I've placed the line, I can still see that there's perfusion getting past the catheter. And this is what we were always taught to do in residency. And I honestly thought it was voodoo for a while until we had a vasculopath come in one night for an emergent surgery. And she was on, and I placed the pulse oximeter, then I did the arterial line, and sure enough, right when I placed it, the pleth on the pulse oximeter was very, very dampened. And she said, why don't you go ahead and take that out? And about 30 seconds later, it resumed back to normal. And I was like, okay, all right, well, I believe you now. And as, as someone who's had family members experience complications from, line placements and things like that, it's something that I take pretty seriously. So I think it always gives me reassurance, and I think it's good practice to try and do that so you can measure, perfusion to the hand and perfusion to whatever extremity that you're placing a line in. So that's one of the things that I like to try and do in my practice.
Well, Tyler, thank you so much for coming by. I really appreciated you coming to join us today.
Yeah, I really appreciate you having me. Thanks so much.
Thanks for joining us for another episode of Style Points. If you liked the show, please consider leaving us a rating or a review. If you write a review, I would be really interested to know where you're listening from. I would love to hear if you or other people from your department enjoy the podcast. What institutional changes are you working on? You can always email me at stylepointspodcast@gmail.com. Take a deep breath. Open your eyes. We're all done.